Hello everyone. In this class, we'll study about the descending pathways. The learning objectives would be to classify the descending pathways, draw schematic label diagram of corticospinal tracts, describe the original course, functions of corticospinal tract and explain the lesions in the corticospinal tract at internal capsule. List the differences between upper motor neuron lesion and lower motor neuron paralysis and explain the physiological basis of these differences and give the course and functions of other descending pathways. So the supraspinal influence on motor neuron are mediated mainly through the descending pathways. Descending pathways are fibers passing downward from different parts of the brain that influence spinal cord neurons. However, all descending tracts are not motor pathways like cerebellospinal and raphispinal tracts that predominantly influence sensory functions. Supraspinal centers controlling motor activities are broadly divided into two categories, the motor cortex and the brainstem centers. Motor cortex influences the spinal motor neurons via corticospinal tract, and brainstem motor nuclei influence motor functions mainly via rubrospinal, reticulospinal, and vestibulospinal tracts. Classification of these descending tracts. Descending motor pathways have been traditionally classified into pyramidal and extrapyramidal tracts. The pyramidal tracts are descending tracts that pass through the pyramid in the medulla. Usually, they are synonymous with the corticospinal tract as corticospinal fibers pass through medullary pyramid. Extrapyramidal tracts are the descending pathways that do not pass through pyramid in the medulla. Therefore, pyramidal tract disease clinically refers to the disease that interrupts fibers of corticospinal tract. Extrapyramidal tract include reticulospinal, vestibulospinal, rubrospinal, and tectospinal tracts. Confusion of pyramidal and extrapyramidal classification. The pyramidal extrapyramidal classification of descending pathway is not appropriate physiologically because all the fibers of corticospinal tracts do not pass through pyramid, and especially most of the fibers in the anterior corticospinal tract bypass the pyramid. Moreover, pyramidal tract signs seen in patients suffering from pyramidal tract disease are not similar with the features of isolated lesion of corticospinal tract produced in experimental animals. Hence, this clinical classification of pyramidal tract is not synonymous with corticospinal tract. And more confusion is created for the extrapyramidal system. Anatomically, extrapyramidal tracts are fibers that do not pass through the pyramid in the medulla. Extrapyramidal tracts originate from the brainstem. Clinically, extrapyramidal diseases refer to the diseases of basal ganglia and cerebellum. However, the major descending pathways involved in basal ganglia function is the corticospinal tract rather than the extrapyramidal tract. Thus, classification of pyramidal versus extrapyramidal pathways is physiologically incorrect. Physiologically, descending pathways are divided into two, that is, lateral system and medial system pathways. This classification is based on the termination of descending pathways on the motor neurons in the spinal cord and the function of the pathways. Lateral system pathways. Lateral system pathways are pathways that descend down in the lateral column of the spinal cord. These include lateral corticospinal tract and rubrospinal tract. The fibers of these tracts placed in the lateral funiculus in the spinal cord and fibers terminate on the motor neurons that are placed laterally in the ventral horn of the spinal cord, that is, on the lateral part of the motor neurons. Thus, these tracts are involved in the regulation of skilled voluntary movements as lateral group of motor neurons innervate the distal limb muscles. Medial system pathways are pathways that descend down in the medial and anterior columns of the spinal cord. These pathways include reticulospinal tract, vestibulospinal tract, tectospinal tract, and anterior corticospinal tract. The fibers of these tracts are placed in the medial and anterior funiculi in the spinal cord and they terminate on the motor neurons that are placed medially in the ventral horn. that is on the medial group of motor neurons. Therefore, these tracts are involved in the regulation of posture as the motor neurons of the medial group innervate proximal limb muscles and the muscles of axial skeleton of the body. So this diagram shows the lateral group of motor neurons where the lateral corticospinal tract and cerebrospinal tracts terminate, whereas this group, this is medial descending system where it includes anterior corticospinal tract, a tectospinal tract, reticulospinal tract, vestibulospinal tract. Some of the medial system pathways like corticospinal tract. Traditionally, corticospinal tract, pyramidal tract, and upper motor neurons are used interchangeably, but strictly speaking, these tracts are not altogether synonymous. There are two groups of corticospinal tract, lateral and anterior corticospinal tracts. Lateral corticospinal tract constitutes about 80% of the fibers of the corticospinal pathway. This is the most important descending pathway for the control of skilled voluntary movements. Anterior or ventral corticospinal tract constitutes only about 20% of the fibers in the corticospinal pathway and is involved in the control of posture. The origin of these fibers, that is corticospinal tract, is from the primary motor cortex, that is area 4, especially from the large motor cells of beds in the fifth layer of the precentral gyrus. There are about 30,000 bed cells in the cortex, whereas about 1 million axons are present in the corticospinal tract, which clearly indicate that the corticospinal fibers also originate from the other areas in the cortex. The other cortical motor areas include premotor cortex, that is the lateral part of area 6, supplementary motor area, that is medial part of the area 6, and primary somatosensory cortex, that is area 3, 1, 2, and the parietal cortex, that is area 5 and 7. Motor cortex contributes about 60% of the fibers, and 30% is from the area 4 and 30% from 6, and sensory cortex contributes about 40% of the fibers of the corticospinal tract. If you see the course of the corticospinal tract, fibers arising from the different parts of the cortical areas converge through the posterior limb of the internal capsule. As the fibers in the subcortical areas appear in a radiating pattern, they are collectively known as corona radiata. After passing through internal capsule, fibers descend down in the ventral brainstem as the cerebral peduncles. In the medulla, fibers pass through pyramid. So that is why it is called as medullary pyramid. About 80% of the fibers after passing through the pyramid immediately decussate, that is, they cross over to the opposite side and descend down in the lateral funiculus of the spinal cord. This forms the lateral corticospinal tract. The lateral corticospinal fibers have monosynaptic connections with the anterior horn cells. The remaining 20% of the fibers descend down ipsilaterally, that they do not decussate in the anterior funiculus of the spinal cord. This constitutes the ventral or anterior corticospinal tract. The fibers cross over to the opposite side only at the spinal segment through their termination on the interneurons. The termination of this corticospinal tracts, the fibers of lateral corticospinal tract terminate on the lateral group of motor neurons in the ventral horn of the spinal cord. About 30% of the lateral corticospinal tracts fibers terminate directly on the motor neurons and 70% fibers terminate through the interneurons. These motor neurons innervate the distal limb muscles. The fibers of the ventral corticospinal tract do not directly terminate on the motor neurons, rather they end on the interneurons in the same side of the spinal cord, which in turn cross over to the opposite side and terminate on the medial group of motor neurons. Few fibers from interneurons terminate on the same side of the medial group of neurons. These motor neurons supply proximal limb muscles and axial muscles of the body. Okay. So this is the corticospinal tract. Okay, so where the they pass they form the corona radiata and they pass through the internal capsule, and the 80% of the fibers they cross at the pyramid, and they're going to form the lateral corticospinal tract. Okay. So then they're going to 70% they're going to end on the motor neurons, anterior motor neurons, and they mainly supply the distal group of muscles, and they are responsible for skilled movements, whereas the 20% of the fibers they descend in the same spinal cord, and they are going to end on the interneurons, and then from there they are going to cross over, then they reach the medial lemniscal system, and then they're going to mainly the innervate the proximal group of muscles where they are important for the postural movements. The functions of corticospinal tract. The motor cortex is mainly involved in initiation, planning, and control of movement. Corticospinal tracts transmit central command signals from the motor cortex to the spinal cord, interneurons, and motor neurons. Lateral corticospinal tract controls skilled voluntary movements of the body, and anterior corticospinal tract controls posture. Effect of lesions in the corticospinal tract. The lesion of the lateral corticospinal tract results in impairment of skilled voluntary movements like writing, painting, but as the rubrospinal tract is intact, the subject recovers after a few days or weeks. However, isolated lesion of lateral corticospinal tract is very uncommon in humans. In addition, diseases that affect corticospinal tract also affect corticobulbar tracts that influence activities of extrapyramidal system. Thus, a pure corticospinal tract disease is not seen in humans. Lesion of the anterior corticospinal tract in animals results in inability to maintain posture while walking, climbing, but in human beings, posture deficit following lesion of the anterior corticospinal tract is not prominent because of two reasons. Firstly, this tract is not well developed in humans, and secondly, the major posture regulating pathways, especially the reticulospinal tract and vestibulospinal tracts, are still intact. Clinical importance. Corticospinal pathway may be interrupted anywhere along the course of the cortex to the spinal cord. However, the lesion of corticospinal tract at the internal capsule is the commonest pyramidal tract lesion, as the fibers coming from different parts of the cortex pass through the narrow tunnel in the posterior limb of the internal capsule. The disease of the internal capsule results in complete interruption of corticospinal fibers. This leads to contralateral hemiplegia. Should be noted that ascending fiber system from basal ganglia and cerebellum pass close to the internal capsule. Therefore, extrapyramidal systems are also affected in addition to involvement of the corticospinal fibers. Consequently, pyramidal tract disease due to the capsular lesion is often termed as the complete upper motor neuron paralysis. The usual cause of capsular lesion is the rupture of Charcot's artery, that is lenticulostriate branch of the middle cerebral artery. So this is also called as artery of cerebral hemorrhage, as it accounts for more than 60% of the causes of intracerebral hemorrhage. Coming to UMN paralysis. Paralysis that results from the lesion of the descending fibers between their origin from cortical motor areas and their termination on the anterior horn cells in the spinal cord is called as upper motor neuron paralysis. Clinically, pyramidal tract lesion is referred to as upper motor neuron paralysis. Features: there will be increase in the muscle tone, that it is going to lead to spasticity. There will be no muscular atrophy. Sometimes mild atrophy may be occurring in the uh, long run due to the disease of muscle, which is called as diffuse atrophy. Muscles are usually affected in groups here. The individual muscles are never affected. The tendon reflexes are exaggerated. The superficial reflexes are lost. There is extensor plantar response, which is called as Babinski sign positive. There are no involuntary movements, that is fascicular twitches. There is no denervation potential on electromyogram, and there will be normal nerve conduction studies. However, if only the corticospinal fibers are interrupted by the disease process that affects medullary pyramid or experimentally produced lesion of the medullary pyramid, most of the above mentioned features are not observed. The most prominent features of such lesion are paralysis or weakness of the distal muscles of the limb and positive Babinski sign. Spasticity is not seen, muscle tone even may be decreased. This indicates that the descending fibers passing through pyramid are mostly fibers of the lateral corticospinal tract. The features described for pyramidal tract disease indicate the involvement of the corticobulbar fibers that influence brainstem motor nuclei in addition to the interruption of corticospinal fibers. The physiological basis of the features of human paralysis. Spasticity. The spasticity occurs due to the increased discharge of motor neurons and increased excitability of the motor neuron pool. In upper motor neuron lesions, not only the corticospinal fibers are interrupted, but also the corticoreticular fibers are damaged. Normally, corticoreticular fibers from the fibers from the motor cortex to the brainstem reticular formation, especially to the uh, pontine reticular nuclei that forms pontine reticulospinal tract, inhibit reticulospinal pathway. Therefore, interruption of the corticoreticular pathway facilitates the reticulospinal activity. Normally, pontine reticulospinal tract excites the proximal extensor muscles. Loss of inhibitory corticoreticular influence makes the reticulospinal tract more facilitatory, and therefore muscle tone increases. Hence, spasticity and hypertonia are important features of human paralysis. Absence of muscle atrophy. Muscle atrophy occurs when either blood supply or nerve supply to the muscle is disrupted. In human paralysis, nerve supply is not interrupted. Uh, Therefore, atrophy is not a feature of human paralysis. However, in long standing cases, mild atrophy occurs due to the disuse of muscles, which is called as disuse atrophy. There will be exaggeration of deep tendon reflex. Usually, upper motor neurons are inhibitory to the lower motor neurons. In human paralysis, loss of inhibitory influences increases the motor neuron discharge. Especially, increased gamma motor neuron discharge increases the sensitivity of the muscle spindle to stretch. This results in increased deep tendon reflexes. There will be loss of superficial reflexes. Superficial reflexes are long polysynaptic reflexes that involve different parts of the CNS, unlike stretch reflexes, which are monosynaptic and integrated at the level of spinal cord. The afferent pathways of superficial reflexes ascend up in the ascending sensory system, and different pathways are the descending motor pathways that finally terminate on skeletal muscles. As afferent pathways disrupted in human uh, paralysis, the superficial reflexes are abolished. There will be extensor plantar response. Corticospinal tract excite the flexor motor neurons and inhibit extensor motor neurons supplying the muscles of digits of the limbs. Therefore, normally stroking the sole of the foot elicits plantar flexion. In human paralysis, disruption of the corticospinal influence on the lumbosacral motor neurons causes dorsiflexion of the big toe and fanning of other toe. So, which is also called as extensor plantar response or Babinski signs positive. So, this is in brief about the descending pathways. Thank you.